Welcome to Lighting Your Way, a podcast featuring exciting, hilarious, heartbreaking, terrifying, and joyful stories of real nurse advocates helping real patients get the best health care. Hi, I'm Nurse Betty Long. Each week, I and one of my nurse colleagues at Guardian Nurses will take you behind the curtain to help you better navigate the healthcare system when you or a loved one is sick or injured. Violence against healthcare workers has reached epidemic proportions. According to a study from the Occupational Health and Safety Administration, also known as OSHA, healthcare workers account for approximately 50% of all victims of workplace violence. Nurses often take the brunt since they are the ones on the front lines, the ones who interact most with patients and their families. While many assaults do not cause serious injuries, some nurses have gotten broken bones, black eyes, and other injuries. In rare cases, nurses have also been killed. In April 2019, Lynn Truxillo, a 56-year-old nurse at a hospital in Baton Rouge, Louisiana, saved another nurse by pulling away a patient who was attacking her. The man turned on Truxillo, grabbed her by the neck, and struck her head on a desk. She died several days later from complications related to that assault. Doctors are attacked as well, but according to statistics from the Emergency Nurses Association, less so than nurses. Among ER doctors, 47% reported having been physically assaulted on the job, compared to 70% of ER nurses. Patients have cursed, yelled, grabbed, pushed, and verbally threatened to kill nurses. According to one ER colleague, that kind of stuff happens all the time. Nurses and their aides are there 24 hours a day, while doctors' time with patients is limited. They come in to consult and they leave. According to one nurses union study, nurses and nurses' aides are 5 times more likely than any other type of worker in any industry to be victims of workplace violence. While legend has it that violence in the workplace happened just to ER nurses and psychiatric nurses, we are now seeing more widespread violence on medical surgical units, labor and delivery units, and even outpatient clinics. Quite frankly, it's happening everywhere healthcare is delivered. We talk today about this sobering topic with Dr. Michelle Conley, Chief Nursing Officer at Jefferson Health Northeast in Philadelphia. Good morning, Michelle Conley. Thank you for taking time out of your very busy schedule to join me on the Lighting Your Way podcast. I am very much looking forward to our conversation.
Thank you.
We're talking today about violence against nurses in the workplace, which I believe is not just a very timely topic, but also critically important. A lot of lay people don't know that nurses are often the victims of violence. When I was preparing to talk with you and preparing for the podcast, I asked a friend if they were aware of the prevalence of violence, and she said, well, who would want to hurt a nurse? So I think that might be a common misconception. What do you think about that?
Yeah, I think that's definitely true, and I think the data bears that out.
Okay, so before we do a deeper dive into the topic, Michelle, tell me a little bit about you. You grew up in Philly, right?
I did. Born and raised in Philadelphia, grew up at a neighborhood called Harrogate, went to Catholic grade school and Catholic high school. Proud little Flower graduate, went to nursing school here in Philadelphia, and have spent my career in various medical facilities in Philadelphia.
So what you went to nursing school at Frankfurt Hospital, I think?
I did. I attended, I graduated from high school in 1981. And
Good
immediately,
for you to admit that.
I'm loud and proud. I'm good. But went, directly into a nursing program. At the time, it was the Frankfurt Hospital School of Nursing, and back at that point in the 80s, there were, a fair amount of hospital-based nursing programs in Philadelphia. And I attended the Frankfurt Hospital School of Nursing, which actually is the school of nursing that is was affiliated with the institution that I now work at.
And you have a great story about when we've talked about how we go into or how why we went into nursing. You have a pretty pretty good story. Do you want to share that?
I don't, I don't know if it's a good story, but it's an honest
It's an
story.
honest story.
Um, I mean, I graduated from high school. I was 17 years old. Neither of my parents attended college. So I didn't have, a vast experience with, what college education could look like or careers that you could sort of pursue. Um, so I really wasn't sure what I wanted to do. I know a lot of nurses tell stories about how, they wanted to be a nurse from the time, they took care of their sick grandmother or, saw something that compelled them. I didn't have any such experience. I really just sort of didn't know what to do with myself. And like I said, I went to high school in Little Flower, and we would frequently, ride public transportation after school to whatever we were doing. And I one day took the Frankfurt L home with a friend of mine, and we got off at the end of the line at Bridge and Pratt. And she went home, and I was sort of making my way back to the L to go back home, and I passed the School of Nursing and sort of wandered in and the recruiter was sitting there at the time. This was behind the hospital. It was a big, large building behind the hospital. The recruiter was there, and I started to talk to her, and I said, this is my SAT scores, and she's like, well, based on what you're telling me, you meet all the criteria to go to school here. And I said, okay. So that was really how I wound up going to nursing school, which is a terrible reason to, but
Well, look,
I
I don't know. You've done well, and
I,
thank God
I
you took
think
that L
back on
route.
it often, and I think, dear God, like what, that's if you talk to, people now, or people thinking about going to school and that was their rationale for attending any program, you'd probably try to, talk them through a little bit. But it really, I feel incredibly grateful and lucky that I walked down Penn Street that day and,
Yeah,
kind of didn't know any better, because,
yeah.
it's a career that has served me well. And I think really, like I said, I was 17 when I went to nursing school and 20 when I graduated as a nurse.
Right.
So I think it really not only sort of has been a wonderful career, but really informed um, who I became as a person, because
Oh,
I,
sure.
was immersed in the profession at such a impressionable time of, all of our lives, that I really think, it really helped form my adult person. So I'm incredibly grateful for whatever, um, you know,
Whatever
kismet or
guidance.
divine
Yeah,
intervention or
right,
whatever it is
right.
that marched me down Penn Street that day when I was 17 years old.
Thank God the recruiter was there when you walked in.
I know, it just happened. I mean,
I know.
it's a really is a very crazy story, but it really is true.
Good story. That's why I said good story. So after nursing school, you went to where? What was your first job?
So, like I said, I graduated, I was 20 years old, graduated from nursing school. And what I have to say was really a very comprehensive program at the time. Nursing education was configured differently than it is now, whereby the program I attended, you actually did a focused semester on various kinds of nursing. So, I spent a semester in the operating room, and I spent a semester in critical care and in the emergency department, and, in specialties like women's and children's and rehab and psychiatry. So, we really got exposed to what the practice of nursing looked like post graduation. So when I graduated, um, I had an amazingly good experience, which I know a lot of people report the complete opposite of that, in my mental health rotation, and really wanted to try that out. So literally went right into mental health nursing out of nursing school, and worked at Friends Hospital in the 80s. for a few years, and then went to the Penn system and spent really the next 20 years in various positions in mental health crisis care within the city of Philadelphia, residential treatment care,
Wow.
taking care of mentally ill adults based in the community, which was a fascinating experience,
Yeah, I bet.
and women's and children's. I also spent a good portion of my time there managing the labor and delivery unit at Pennsylvania Hospital and serving as the director for the women's health division and the division of psychiatry there. So, really had as a clinical nurse, interesting, I think, career trajectory and lots of really um, different experiences than many other people have, I think.
Yeah, and I think, and then you went to into nursing leadership at what was then, I guess, ARIA.
Yeah, so I had held manager positions and director positions at Pennsylvania Hospital, and then was the associate chief nursing officer there. And when I left there, came to what, as you indicated, Betty, ARIA Health in 2011
Okay.
as the chief nursing officer, and that's the position I'm in now. However, we are now Jefferson Health Northeast because we merged with Jefferson several years ago. So we are part of the larger Jefferson system.
So, Michelle, you've been the chief nursing officer since 2011, as you said. And in those 10 years, let's talk about our topic now, the violence against nurses in the workplace. In that time frame, have you seen a change?
Yes, I think, it's interesting. I think, as a long-term nurse, and a nurse who worked in settings where, violence is certainly can be prevalent. I do think that we've seen some changes, and I think the data supports, that violence just in general in our society is on the uptick and is rising. And, I think workplace violence, you don't have to do much but watch the news to see that, violence in workplaces is on the rise as well. I think what's interesting and what I learned was that, if you look at OSHA data, which is, the safety data for workplaces,
Right.
of all workplace violence, about 50% of OSHA's data says that violence takes place in healthcare environments. And I think for most people, that's kind of a shocking
Wow.
statistic because
Yeah,
we
sure.
don't think of hospitals or places where you receive healthcare as places that, see a lot of violence. But I think that's a pretty compelling number and a pretty compelling statistic to make us really sit up and take a better look at what's going on in our healthcare settings.
Yeah, I mean, most folks would probably say that they would want to feel safe in a hospital. The patients might feel safe, but perhaps the nurses and doctors don't, or techs as well.
Yeah, I think it depends. There's when you talk to people who provide healthcare, I don't know that there's a real appreciation for what violence means in healthcare. I think we take it for granted a little bit,
Okay.
and many people view it as sort of just part of the job. And people will say that, very, very candidly when you talk to people about, what their experience has been with any form of violence within the context of their job. It's just sort of assumed that kind of goes with the territory. And I think, that mindset and that paradigm needs to shift as well. We can't just sort of shrug it off as, well, this is just part of our job. I think we have to sort of position the topic and think about it in a way that it's something that we want to avoid at all costs and mitigate in any way we can.
Right.
And I think that, again, the data supports that when you put very structured strategies in place, that you can do just that.
Right, and I think there's also a misconception. You and I have talked about this before, that the violence coming to nurses and doctors and techs is coming mostly in the emergency room, and that bears out. But I think that your experience as a chief nurse would tell otherwise.
Yeah, I mean, obviously, right, the emergency department is, ripe for that, as emergency care providers. Um, those clinicians are working with people coming immediately from wherever they're coming from, right? So whether it's home, whether it's a crime scene, whether it's an accident, they leave that setting and are immediately in the healthcare setting.
Right.
Whereby in other parts of hospitals, at least, people kind of make their way to you either electively because they're coming in to have surgery or some other kind of procedure, or, after being in the emergency department and stabilized somewhat. So yes, you definitely see different kinds of violence and some increased numbers in emergency departments and psychiatric settings, but med-surg units and even critical care units aren't without violence as well. So it really is, it is a phenomenon that we see throughout our hospitals, not just in those very specific departments, though it does look different in different places.
Wow. Yeah. Do you have a mental health unit?
We do not in the hospitals that I have responsibility for, but Jefferson has a mental health unit at the University Hospital as well as in New Jersey and Abington, but we do not have one here.
Okay. And so a couple of years ago, you told me about a program that you and another colleague at the hospital created. Can you talk a little bit about that? It was designed, I think, because you were hearing from nurses in the ER that there was more violence. Tell me about that.
Yeah, so we kind of coined our project after the fact, Operation Safe Workplace, because the information came to me quite anecdotally, which I think is part of the problem. It was not highlighted in any way in the data or in our safety committee or in our environment of care that we had, an issue with this or something that maybe would have needed more attention. And literally, I just heard a story one day about a nurse who had been assaulted in the emergency department and was assaulted pretty significantly. She was caring for a patient, and when she leaned across the patient, the patient sort of took her head in a headlock with her leg and kicked her repeatedly in the head. So needless to say, that's, in my mind, thinking a pretty significant assault, regardless of where it happened.
Right.
So I learned about it, and I went to the emergency department to sort of see what was going on, just, to express my concern and see if I could be helpful. And what I found at the time was that no one really seemed all that fazed by it. The nurse, I talked to the person who was the charge nurse at the time, and the nurse who had been assaulted was being cared for, so I didn't speak to her right away. But no one in the immediate environment really was as sort of horrified by it as I was, and that sort of was the tipping point, I think, for me to start to look and take a deeper dive into, what did that look like for us here, and what was the magnitude of our issue, because what that event told me was that people were likely not reporting it. People were sort of just taking for granted that was part of their day, and we may not completely understand all of the magnitude of the issue of workplace violence within our own institution. So that really was the thing that really kind of triggered us to start to take a deeper look.
Wow.
And what I found at the time really was that there was no real one-stop shop where I could go look as, the nurse leader to say, do I have a problem with this? How many nurses do I have that are being injured each year? And I really started to just pull information from different sources. So I went to our event reporting system and asked them to kind of run reports for me out of that would give me the information I was looking for. I went and talked to the security officers and just asked to look at their logs, to go through the things that they logged in terms of their workday documentation to try and get a sense of, where and when were these things happening and what were the circumstances.
Right.
We looked at our workers' comp data, right, because that will, I suspected that would tell me if people were seriously injured enough that they needed to be out of work,
Right.
that I could sort of go back and kind of trace that data. And that's really where we started, was really looking at all those kind of data points, if you will, that you can pull out of a hospital. Now, those things are tracked better now than they used to be, so it would be a little simpler and easier. However, I think, what we found at the time was that it really provided us with a much richer story, if you will, as to what was informing that than any one data point did.
Yeah, and to your point earlier is that if it's underreported,
Right.
then you're kind of blindly trying to set up a program, but you don't think maybe there's 5 people, maybe there's 500 people.
Well, and if people aren't, and people don't report for a million reasons, right? They don't have time. A lot of times, nurses will wait till the end of the shift to put something in the event reporting system that, that they think is event report worthy. Sometimes people would be embarrassed, to be honest. There were people who didn't want to admit that they had been assaulted because they saw that as some kind of, personal failing per se. There were a multitude of reasons that we found that it was underreported. And I think just the mere fact of talking about it
Right.
and asking people to report it
Right.
made a big difference for us. We definitely saw, once we started to launch different pieces of our program, that people were much more willing to report it once we kind of took any stigma away and asked them to do it. We started to see much more of that.
And did you define, because I know that when you look at the definition of workplace violence, it could be anything like a patient yelling and verbally abusing you versus the physically abuse, right? So when somebody cursing,
Definitely, and
spitting,
I think when you think about it conceptually, violence isn't just physical. I think a lot of times we sort of, when we think about it, we think about violence as someone sort of physically harming another person, but emotional violence or people really verbally assaulting staff is also a very large issue in our hospitals. People who come in for a multitude of reasons and with a multitude of cognitive or physical issues, can behave that way at times. But I think as we've also seen kind of shifts in just basic human civility and, respect for other individuals, we've definitely seen an uptick in both the physical as well as the verbal assaults that we encounter on any given day.
right? You're not. The hospital is not the hospital is not.
I don't know if this is what you're trying to say, but I think that, there was probably a time where hospitals, not unlike schools, were kind of sacred places where
Yep.
people behaved differently, right? When you went to the
Yep.
hospital, you were going there to be cared for. It wasn't a place where, again, you would expect to see or experience those kind of things,
Right.
whereby that kind of shroud of, doesn't exist anymore.
Right. Yeah, if we're shooting children in school, then why should an ER be safe, right? Okay. So tell me about the program. So after you've gathered the data, you and your I think it was director of security, kind of put your heads together and came up with a program.
Yeah, so when it started to dawn on me that this was probably something we needed to take a better look at, it became clear to me very quickly because I learned a lot in terms of talking to our safety and security folks as well in terms of their approach to all of this. So I reached out to the gentleman who was very new to our organization at the time and had just started, to sort of sit with him around this topic and convey to him sort of where I was coming from and ask him to partner with me in terms of really taking a more critical look and really trying to come to some understanding as to what were the driving factors, what was causing this, what were the things that we were potentially already doing, and was that helping? And if so, how could we start to talk about that more? And then what were our opportunities in terms of maybe looking at this issue a little bit differently than we had in the past? And to my great happiness and gratitude, he was incredibly responsive and embraced this from the very beginning and completely and fully partnered with me on this. So we literally sat down and, we started to look at, what we knew about our own current information and then, looked out to the literature. And, I think what was nice for me as a nurse working with him was, I knew to go to the nursing literature and the OSHA, like workplace safety literature. But there was a whole body of safety and security literature that I frankly wouldn't have occurred to me that it existed or to look at, that he thought about and went to, and to his professional organizations as well as mine. And then, we came back together to kind of put together, our plan and how we were going to take a look at and do our own internal risk assessment. And really what we did was we sort of just took that information and decided, our best course of action at that point was to, what were the programs we had in place? And we had a de-escalation program that we used at the time.
That had already been in existence? Like you still...
We had some policies about it, but they weren't anything really compelling or, effective. So we decided what we should probably do is just kind of go on the road, and we set up, probably it was weeks worth of just what we were calling focus groups, and they were very informal. We would let the department know we were coming. We went, on the day shift, on the night shift, on the weekends. We made sure that we tried to hit every sort of opportunity where someone would be willing to talk to us about this, and just really started to just sit down with people. And we had some basic questions, but mostly we asked them, what is your experience with violence in the workplace, and how has it affected you, and what do you think will help? That was really the gist of our assessment tool, and it was incredibly enlightening. And I think one of the things that we learned very quickly was that even though people weren't reporting it, once we were coming, respective of our positions, they were willing to talk to us and tell us. So, we talked to everybody from, the obvious folks like the caregivers we've talked about in the emergency departments and, on the units. But we also talked to people like the valet parkers, and the people in registration, and those who sat at reception desks, and anywhere where people were encountering sort of the public or our patients, and could potentially have interactions that would inform us as to what was driving our problem. And it was incredibly enlightening. And what we did was we sort of cataloged all of our interviews. And then we went through and did our work plan based on that. And we broke things down into a couple of categories. So we broke one thing down into just environmental things. So what were the things in our environment, whether it was, the terminology that we used on signage, was it very directive and maybe aggressive, to how things were laid out? Did we sort of squish people into environments where when you squish people in, it's going to agitate them? To our panic alarms and our lighting, et cetera. We did the second category is our policies and procedures. So what were all the things that we had in place from a formal perspective in that space? We looked at all our technology and equipment. So what were we using in terms of safety? Again, whether that was cameras, whether that was panic alarms, and if we had them, where were they, and who did they alert, and what was the process for that person to be alerted? And then lastly, and we broke this one out a little bit around two things: communication. So how were things communicated? How did we identify people who maybe were escalating? And then how did we communicate that amongst caregivers, and then people? So how did we train? How did we educate? How did we make sure that all of our employees had a sense of this topic, and what were we going to do around it?
Wow.
So we really, needless to say, we found a lot of things, and we found a lot of things that we could impact. And, I think a lot of times when people start to go down these roads, frequently where we land, especially in hospitals, and I think maybe even more so in nursing, is we say, oh, we're just going to provide this new educational program to people, and that's going to address
fix it.
issue.
Right.
And it's an absolute and important component, but it's not comprehensive enough, and we found that very quickly. So, we looked at all our policies, everything from our restraint policies. How did we manage one-to-ones when people were on one-to-ones?
Okay.
How did we manage our various spaces? Did we have a workplace violence and safety policy that was specific to that, which we didn't really? How do you manage people who are disruptive? Where our hospitals sit, we get lots of patients from the prisons because there's several prisons down on State Road. So how did we manage both the prisoners as well as the officers that were with them, because they have weapons?
Wow.
And did we have really tight processes around that? We looked at our security cameras. How did we communicate with law enforcement? So when law enforcement would bring patients to us, did we have a very structured way of communicating with them? How could people enter and exit our buildings? Were they secure? Did we have metal detectors or not? And at that time, we did not have them at all of our entrances in the ERs. Panic buttons.
Do you have them now?
We do.
Okay. As a result of this program?
Yes.
Yeah.
So we put, as part of our plan, we put that in, that we wanted to have metal detectors at the fronts of the entrances to the ERs.
Wow. So, I mean, this sounds like a very thoughtful and well-designed program, pretty comprehensive. How long did it take you to do all this work?
It took us quite a long time. There were some things that we could do quickly, right? We could, like I said, the focus groups took us, probably 6 to 8 weeks to just conduct them. But we really felt that it was important to hear directly from the people who were experiencing it,
right,
in order to inform where we went. Because you could make a lot of assumptions, right? You could make an assumption that, well, if you just put in a metal detector, that's going to solve X% of your issues. And yes, it's a really important component, but just to put a metal detector in isn't going to make your workplace safe.
Right.
It's going to help you not have weapons come through your door that maybe are coming through now, but it's not going to give you that comprehensive really look into what's causing every bit of violence that you're seeing in your workplace. So we really were very deliberate, and it took us probably the better part of 2 years to really get through everything. I mean, as you can imagine, there was capital monies that we needed to, make a pitch for and actually get, and, it's never easy to install anything in a hospital between, needing to do inspections and talk to the Department of Health, and, they're all very, very time consuming. But I think once we had a really clear blueprint and we took it to our senior most leadership and we got buy-in really quickly, that piece of it kind of fell away. And that's where a lot of people get, where they hit a roadblock. It's hard to get past that.
Okay.
I think because we did really have good data and we had a really comprehensive risk assessment of what was causing it, that it gave us a level of credibility when we went to the people that we needed to go to for whether that was money or permission or, policy changes or changing how we changed some of what security, how they approached their jobs.
Okay.
So that's not simple, right? They had, at the time, the previous security director had kind of a hands-off policy. So that was problematic, needless to say. And that sounds really silly to say, but what we found was that wasn't really uncommon in some places. We didn't really have a sense of team around how you respond to these things. People responded, but it wasn't in a thoughtful and structured way. So once we kind of looked at that and really put the appropriate training in, we changed up the training and the accountability so that there really was a team that was responding, and the level of support or perception of support, really, because we didn't necessarily add a team or create a new team. It was sort of, we reconfigured the roles of people when they responded. And then really just talked about things like, we heard a lot of themes around, internally people disrespecting one another just amongst the team, that at least the perception of, or futility, like things didn't matter. It didn't matter what you did, or it didn't matter what you said, and helplessness, and obviously some anger around it. But once we sort of identified what those emotions were and what the drivers of those were, then we could start to address the things that were causing it. And once you name it and you start to think about it that way, you can start to chip away at the causes.
And as a result of this program, now in 2021, do you feel that your nurses are safer?
I think for sure they're safer than they were at the time when we started the program. I think, interestingly enough, and it was one of the things that really kind of struck me when you asked if we could talk about this. I just recently met with the person who I had done this project with to say, I think that we need to kind of go back out on the road again. I think it's time for us to refresh kind of what's going on and what are our areas of opportunity, because things have changed since then. We were a freestanding organization when we did this. We didn't have the resources that working with an organization like Jefferson comes to bear. We're on the cusp of disseminating a wearable technology that all of our clinical staff will wear. It's called Strongline, and it's a Jefferson technology, Jefferson developed technology that's in place. It's been implemented at the University Hospital and in New Jersey, and we're about to implement it here in the next several weeks, which is a game changer. So there's sort of it's a perfect time for us to kind of put fresh eyes to this issue and look at what we probably should be doing differently. So we have literally just embarked upon that in the last couple of weeks.
That's great. And so tell me, let me just switch off for you. Way back when, have you, when you were in the clinical setting, were you ever a victim of workplace violence?
I was, and I think I was probably kind of that quintessential person that I described at the top. I kind of, I became a nurse when I was 20 years old, and I knew what I knew about my work experience, and certainly saw violence in my work environments. It was usually pretty well contained and well addressed, but I did view it as just part of my job, and that it just went along with the territory. And I'm sure I was very guilty of not reporting things that I should have reported. Not willfully, but just it didn't probably occur to me. But I have been certainly verbally assaulted on more occasions than anybody
and not
probably
just
should be.
And not just by patients, right?
Yes. For the sake of this conversation, yes. So that, and again, didn't really think too much of it, even when it was hurtful or it, caused me to feel a certain way. I don't know that I really thought, well, this shouldn't happen, or this should happen less, or there's something that I or someone else should do about it. Right. But had also been certainly physically assaulted, when you think about what nursing care looks like and just the practice of nursing, it's incredibly intimate. So you are, sometimes in very close contact to people physically, and even the emotional part of it. You're talking with people about things that, you know, sometimes they don't talk about with their closest loved ones. And that intimacy, I think, allows, or not allows, but sort of opens the door to then that level of aggressiveness. So, you know, I've certainly been punched and bitten, and I had a patient who at one point had sort of grabbed me by the hair and wouldn't let go and pulled me, you know, down. Now, in all those circumstances, none of them was I alone. So there was always the team of people that I worked with who responded, and, you know, we kind of kicked into that team response. So, and certainly witnessed, you know, just as many accounts of that happening to other people.
Right. Yeah, I mean, working in critical care and in long-term care, certainly, it's never been physical abuse that I've experienced, but I've certainly had my share of verbal abuse.
Right. I mean, I think I don't think you could find a nurse, frankly, you know, that could say, no one has ever called me a mean name, you know, or been particularly, and some vicious, you know. I mean, you know, people can be incredibly verbally vicious. And that's hard, right? I mean, you have to continue to work professionally. You have to continue to care for that person because you're their nurse. So you can't just be like, you know, you can't buy a cake here, you know, please leave my bakery.
Right.
Because you're acting, you know, the way you're acting. So it's a different setting, and I think, you know, we've learned to behave differently, probably not in a good way, and, you know, I think in some ways we've conveyed to the public that it's okay to do that. So I think as we, as a profession, start to say and draw, you know, sort of draw that boundary that, I mean, I don't think it's realistic to say it would never happen, but I think it's realistic to say that anytime it happens, it's not okay. And that there's something we can do to either intervene or mitigate. And I think that's just a paradigm shift for us in healthcare.
So, Michelle, this is what, you know, the theme here. We often ask our nurses who are on the podcast, what one thing, so I'm going to ask you, what one thing would you like to share with maybe nurses who are listening, and then secondly, with patients who are listening about workplace violence?
That's a great question. And it's really hard to answer. I think the one thing I would say, and I don't know if this is probably the most effective, but the thing that pops to my mind right away is that I think just a general sense of human respect and kindness can take a lot of what people encounter out of the situation. And if we can get ourselves to a point where we're all looking at each other as, you know, fallible human beings who are in a situation for a reason. So whether you're a patient and you're terrified and, you know, in an emergency room because of whatever you're experiencing, or you're a nurse who is in a situation that could be equally as terrifying for other reasons, depending on how a patient is behaving, that we're all here for a reason, and that if we focus on that, you know, we can get the patient better or cared for, and we can do it in a way whereby a nurse or a caregiver can walk away from it feeling like they did their job and didn't have to encounter anything adverse like violence in their workplace.
Well, that is a wonderful piece of advice. Thank you.
I don't know.
Really?
It's probably not the most pertinent, you know, there's probably a better answer to that question for this
I think
topic, and there's probably other things that we can and should be doing as well. Like I said before, I think there's so many pieces to it, it's hard to encapsulate it into one, but I think one of the things that we've definitely seen in this work is that there has been a degradation of that on all sides, and if we can all kind of get back to a place where a hospital is a place where someone comes for help and there are people there who are there to help them.
Right.
That's a really good start.
Yeah, I think being kind, being nice, being civil is certainly a good place to start, and we can
Yeah,
deal with the policies and procedures later.
exactly.
So thank you very much for taking time. I enjoyed the conversation. I think that our listeners will as well. Take care. Keep up the good work.
Thank you, Betty, and thanks for having me today. I think it's really, I challenge all your listeners to go out and thank a nurse for what they're doing.
Wait, good advice, Michelle, as always. All right,
Thank you, and thank you for having me.
All right, take care. If you have any questions that you would like us to address in a future episode, please email us at podcast@guardiannurses.com. That email again is podcast@guardiannurses.com. We would love to hear from you. Thank you for joining us this week. You can find the Lighting Your Way podcast on Apple Podcasts, Google, YouTube, Spotify, and Stitcher. If you liked what you heard, tell a friend and leave us a review. You can learn all about Guardian Nurses Healthcare Advocates on our website, guardiannurses.com. So until next time, find some joy in your life, pet all the good doggies and kitties, and remember to tell your people that you love them. Take care.